Good afternoon for everybody. This day, we have the awesome opportunity to have Dr. Phillipe Benoit here. Dr. Phillipe, since many years, is taking care of the horse of French team competing in the show jumping. Earlier, as a French team doctor, I owned the years 1992 to 2000. Now, as a consultant, he cares about the health and the best form from elite sport horses during competitions, training, and rehabilitation. From his experience, also benefit other national teams, including US and Saudi Arabia, the team doctor during the Olympic Games in London 2012. In 1989, he graduated from the Escuela Nacional Veterinaria d'Alfort, and 2 years later became a university teacher in the field of exercise physiology and nutrition of sport horses, being involved in several research projects conducted by the Alfort Veterinary School. Dr. Benoit founded Clinic Equine des Breviers in 1993. The range of services of the clinic is primarily orthopedic, sports medicine, and internal medicines. Doctors working in the clinic have big experience in the prevention, diagnosis, treatment, and rehabilitation of lameness and poor performance syndrome. As a rider, has now the French University Championship in WKK way in 1991 and 1992, and the fifth place in the University World Championships. Very strongly associated with the PAY as a member and co-founder of ISHBA. Dr. Phillipe prefers teaching in a highly interactive environment of open discussion and exchange of ideas. Every year, he conducts many lectures and workshops around the world on topics related to lameness in horses, using ultrasound and orthopedics and in other areas of sport medicine in horses. Welcome, Dr. Benoit. It's a pleasure to have you here today.
Welcome, everyone. Many dos. That will be the only Spanish part. At least I am happy that I have a lot of South American friends and colleagues listening today. South America is always kind of my preferred part of the world. So welcome to everyone. I will start the presentation. So you will see my face disappear and only the screen with the first slide. It's a meeting I have presented at the AAP. So this lecture was done last December for those who need to see what was then. It's a lecture about the low back and pelvis related discomfort. And as you know, it's not always easy to see horses which are really lame or really showing problems in terms of clinical evaluation for this counter performance on a sport horse, which means that these horses most of the time are not always lame, but they always show enough discomfort for suddenly not be able to do the job they are supposed to do, which means jumping for jumpers, dressage, horses who suddenly lose scope and lose elevation when they work, and somehow horses which in different disciplines cannot pivot, accelerate, push off the ground. And in every discipline, like even in polo, for example, I know that horses could have this low back pain and they will not accelerate the way you expect. You will not be able to catch the ball. That's part of the things that for me are called counter performance. So when it comes to the problems, I will talk a bit about jumpers because this is what I do the most. But these show jumpers, for example, here is a horse who was very sound, but except that on the jump, if you look carefully, the video might be a bit slow for some guys, but look that on the video, the horse is going completely sideways. Here we'll do one more clip so you can see. And you see when you have this impression of horses which are not jumping straight or putting the leg on one side or the other, these are horses who actually do have something wrong going on, and we have to find out what it could be. So first you can help the horse and then the rider or the trainers. This horse actually had moderate back pain, mostly at the level of the withers. The saddle fitting was good. The rider, I think, is good enough. It's Eric Navet. For those who don't know him, it's one guy who has been 3 times world champion, so maybe one of the best riders on the planet. And when it comes to jumping after blocking the reverse, this is what we have. The horse is completely back to normal and jumping completely straight, as you see on the fence. So this is interesting because these are mild problem of horses that you can meet, which are not a big deal for the vet because the horse is completely sound when you look at him on a straight line and circle. But when it comes to do his job, which is jumping, he's not doing it properly. This horse was 6 years old. We gave him 2 months off. I did a small mesotherapy on his back. His muscling came back to normal. His pain went away and he started to jump straight again with no difficulties. So when it comes to this type of problems, again, this is another case of a horse. This is slow motion, so it will be, I guess, easy for you to see on your screen. That's a horse which is, again, completely sound on the exam. You look at him on a straight line, on a circle, on a hard ground, on a soft ground. You do hoof test, you do board extension test, everything is normal. The problem is these horses who have back problems or mild subclinical feet problem, for example, you will see it only when the horse is in a strange amount of load and exacerbated movement like the jumping. And this horse, as you can see, will on the second fence, it's a horse we started to block to find out what was wrong because he was completely sound, as I said, and we end up to block his feet and block his back, and this is what we can get afterwards. So this horse changed his scope, changed his way of jumping by just doing a proper, let's say, blocking of the 2 things which were suspicious to look at on the videos. So I can show you again quick this video, but look at the scope on the jump on this video compared to this video. So I will make a break on this one so you can see how much the horse extends. And you will see on this video how the horse scope is different. So just by blocking his feet, and the fence obviously is also very different in terms of size. This jump is much higher than this one. So this is what we obtain with this particular case. When it comes to the horse physical exam, you have to remember that when it comes to counter performance, there's a lot of things that the rider will feel and the vet will not see. The best example I can give you is when you check a horse, part of the examination is when the horse is cold, and most of the time this cold discomfort, or these horses, for example, which are a bit footsore, cold back, you will never see something wrong. The horse is back to moderate amount of work. So when the rider is riding the horse and the horse does a bit more exercise and warms up, then you can see with the rider that there is maybe something that shows up to be different. And the reason why is because most of the exam we do as vets don't last more than 10-15 minutes in a dynamic part of the exam. So things that you see could be coming up as the horse warms up. But when the horse warms up, most of the times you are already in your car going to the next client. So this is something that I want you to evaluate as well. So it means somehow that you, if you can trust, obviously not every rider, you have to make sure that you can do something in the meantime that we can do in terms of follow-up, and maybe look at the horse under tack to pick up more abnormal findings. And this is what is wrong also with most of our exam. And that's why also I respect a lot of my colleagues from South America, because a bit like in France or in Spain or Italy, where I used to work a lot, we don't have all the toys. We don't have the MRI and we don't have all the bone scans right away. So you have to be good at observation. You have to be good with your clinical exam. And I have found a lot of colleagues who have too much tools and too much technology not being so confident with their clinical exam. The contrary is what I have seen when I went to Argentina, Brazil, Colombia, and some other country where you live, where people have to be super careful with observation, try to get as much information as possible, because we don't have bone scan every corner of the street. So you have to take into account your history of your horse, do a good palpation, try to find the type of lameness, the flexion test, the footing where you evaluate the horse, any joint abnormality, distension, in hand, under tack, And then you can do your blocks, and then you can think about some clinical conclusions. And what I like to do is to make sure that at the end of the first part of the exam, which is the horse standing, palpation, everything when it's cold, make a list of what I find, 1, 2, 3, or 4 findings, and then move on to the next step, which is looking at the horse moving. And maybe moving, you can find some interesting things which are in relation with what you have seen when the horse was standing. And therefore, you can use your dynamic exam almost like a complementary exam of what you found during the palpation. And this is super interesting because it helps you to be more accurate with what you palpate, the range of motion of the front limbs, hind limbs on a regular basis. Okay? So at this stage, when you get to imaging choices, you can make some for sure decision with your clients not to pay for every X-ray, every scans of the horse, but you can find a few options to decide what they can experience and what treatment options obviously will come afterwards. So when you do a very thorough static clinical evaluation, you want to check the palpation of the back, the defect and the range of motion of a segment of the horse, some muscle loss, amyotrophy, muscle spasm, limb lameness that you can note. And this is by just doing your physical examination. What is interesting, as you can see on this small study that was done in 2018, is that in 2006, people were doing much more diagnostic analgesia, checking their neurological examination, making sure that all the physical exam was very well done. And in 2016, a lot of vets, it's the same for the human doctors. They don't touch you anymore, they don't palpate anymore, and a lot of things are just stayed backwards because they don't want to evaluate and take time of a physical exam. So I strongly recommend that if you are in this young generation, you try to make sure that you will have access to this type of strong physical evaluation, and make sure that you don't forget to take time to palpate the horse before you're jogging. Once the horse is jogged, when the horse is moving, your dynamic exam will unfortunately make disappear a lot of small back spasm, muscle spasm or muscle tension, and even the range of motion of every joint will change as you move forward. So continue to do a good, thorough physical exam. When it comes to the type of palpation and evaluation, you look at the posture of the horse, the conformation, and some horses have very asymmetric back, like this horse that you see here on the top. I hope you can all see the very strange asymmetry between left and right. This horse has a chronic tubercocci and tubersacrale issue on his helium wing on the right side. But you know, with time, these horses sometimes function completely symmetric, which is always a big deal because you would say that this horse is always lame. Once the muscling is coming back to normal and you see that the muscling shape is actually quite good on right and left, this horse was very sound. This horse had a sudden amyotrophy of his right gluteus. And this horse had to have a sudden atrophy like this, something wrong, which is actually a nerve pinching and a nerve inflammation at the level of his facet L3, L4, L5. And we found an hematoma there of a horse who was sitting in his stall. He maybe got injured, we don't know, but ended up to have this strong amyotrophy in just 10 days. So when you have an amyotrophy that occurs to be very early on, it means that you have a neuronal or neurogenic problem as well. If this type of amyotrophy, like this horse here, happens to be within a few months, it's a misuse of the leg. So in this case, the primary problem should not be the back, it should be a lower limb issue, okay? So these are the things that you want to always look at to understand why a horse like this one as well does show a significant amyotrophy, and always ask the owner or rider or trainer if this horse has lost muscle in a small amount of time or not. So when it comes to palpation, I like to do first a superficial palpation by putting my hands on the top of the horse and check the fascia, the superficial muscles and see if I have a strong density. You can also evaluate the skin and the subcutaneous tissue, because horses who have chronic spasm, the skin looks like it's sticking to the underlayer tissue, underlayer muscle. When you do your deep palpation, it also gives you an idea of the function of the lower structure, deeper structure, which are the core muscle, like the multifidus muscle, we will talk about in a second. Also about the joints, so facets. And then you can look for any segmental focal type of pain, which is sometimes interesting because the back, as you know, is the succession of segments, succession of vertebrae, which you want to be able to squeeze one by one to see if there's one segment which is maybe more affected than the other. And that's very interesting because when you come to different sections of the back, as you know, the main part of the motion is under the saddle, which is not making sense, I know, but most of the back here has large disc under the thoracic spine from T5 to T18, and the larger disc is around 11 and 12. Then you have, again, a joint which is very mobile, the thoracolumbar joint, because it's between T18 and L1, and then you have no more ribs, so there is supposedly more lateral motion. And when it comes to the lumbar joints and facets, as you know, these facets are very tight and close to the midline, so there is not so much possibility of movement laterally, but more movement in flexion or extension. Obviously, you have to check when the horse is cold or warmed up. When he's warmed up, this motion will change. And if it does not change, you know that you might have some joint disease. And it's actually a good diagnostic to make because if it's only the muscle which is not moving, when they warm up, most of the muscle, even us, we can still have a good type of motion. If this warming up does not change, you know that you may have some spinous process involvement, joint disease, or any other ligament and joint combined disease. So this is why I like to pick up the legs on the horse afterwards, because this lack of motion can give me an idea of how much the horse is happy to give his hind limbs. And you see, when you pick up the hind limb, you already start to make a pelvis test and a low back test. So never forget that when you pick up one leg, you're going to create a torsion of the thoracolumbar space, the lumbosacral space, and the SI joints. At the same time, for sure, you are going to flex the hip, the stifle, the hock, and somehow the fetlock behind. So one test that I can show you here is a woman who is doing a bit of movement up and down on the tubercocci. And this is a nice test to do to check the slide and the movement of the pelvis sideways. So it's a good combination between this test and this test to see how much, for example, sacroiliac and lumbosacral movement you can get. When I do this test myself, I like to see and look at the hind limb. So look at my arrow here on the left hind, for example. If I do this test on the top, I want to see how much the horse is loading and changing the position of his fetlock down. Because if the horse fetlock does not drop, it means that he has also a rigidity or some stress and strain within the hock down or the suspensory apparatus, because he will not change the position of his fetlock, and it means that I may have some fibrous tissue or pain when the horse has to load on his fetlock. So these are similar tests, but look, this horse, for example, I pick up the leg. I'm going to go slow to pick up his hind leg. And when I pick up the hind leg, I should have progressively some movement of the pelvis. And some horses are very, very difficult to pick up the leg, and they will lean on you. They will put more weight on you as you go up. So if the horse is not happy with that, I let go, and I go on the other side to see if the horse is changing. But this horse pelvis stayed completely straight, which means the horse was not happy for me to tweak and to rotate his pelvis. This is a very similar case. One of my associates tries to pick up the leg, and the horse will not let him flex completely. Okay, and this is finally when you warm up and be gentle and progressive with the horse, get some movement and rotation of the pelvis. This one is very unhappy when you pick up the leg. He's going to lean completely on the vet, and she tries to flex, but the horse is not happy to do it, and for sure she's not happy as well. So when I was coming back to this study, look at the statistics. It's very interesting to see that at the time, when in 2006 people were looking at the horses and see if there was some back problem and back pain, the difficulty on the ride and the resistance to work was seen by 96% of the vets, and nowadays would be 78%. The modification of the jumping style and the poor performance were looked similarly, but always you see the percentage of the respondents in 2006 were much higher. And the reason why is because I guess, as I said before, in 2006, with less technology, most of the vets were looking at having more time for the physical exam and not looking too much at the technology, which means that today, some vets, they are just maybe lazy or they don't do the job as we used to, and they are sending the horse for a bone scan right away before they really find out what was wrong. And then what is your problem? You send the horse for a bone scan. Okay, that's great, but if the result comes back and you have the horse bone scan which is lightening up on certain areas which are not of your interest, if you have not done a good physical exam, you don't know if this uptake on the bone scans are always relevant or if they are. So again, your observation must lead you to make a list of suspicion, and if these suspicions are seen on your exam when the horse is jumping or when the horse is doing some polo or some dressage, and then you see the bone scan and there is, for example, a horse with a resistance when you do the pelvis flexion and movements, and you have a strong uptake on the SI, yes, this is relevant. But if you have suddenly a hind fetlock or a low neck problem on the same side, what would you say? Is it relevant or not? For me, I still want to observe and make sure that what I see is relevant before I look at the images. So when you do a dynamic exam, as you know, there's a few things you don't want to miss. One of them is to do, on my opinion, the figure 8 at the walk. The reason I like the figure 8 is because the horse does not go too far away from you. You can see the cranial face, the caudal face of every stride. So as you remember, when you have a horse movement, first you have the cranial face of the stride with the front limb going away and forward to the body, and you have the stand face when it's perpendicular to the ground, and you have the caudal face when it goes behind this vertical line. And this caudal face is also the propulsion face. That's the moment where the toe is going to move away by pushing the rest of the body forward. So this is why it's called the propulsion face. So when you look at these horses on a figure 8, you can see a nice, normally, angulation going forward, the loading face and the caudal face. So if one limb is not showing a nice pendulum movement, like a pendulum, you know, moving forward, backwards, then you can characterize the gait problem by being either a defect of caudal face, a defect of stand face, and a defect of caudal face. And that's how you can distinguish problems which are upper limb or lower limb. Most of the upper limb problems are a defect of cranial face. When you have a lower limb problem, most of the time you have a less caudal face, a lesser or not as good caudal face. For the front limb and for the hind limb, it's true. When you look at the horse on the circle, this is a slow motion, so don't check your video trying to get it faster. It's normal, it's a slow motion. I like the horse to have a nice elevation of his back. The mid-back should go up and down. I like to see a nice stand face and caudal face of the stride of the forelimbs. And because we look at the back problem and pelvis problem, I want to see the horse having this type of nice elevation over there. Look at the hind feet. They go off the ground. And what you can see as well is you have no dragging. A lot of horses who have back pain, pelvis pain, low back problem, they will have the hind feet which are grinding the ground. They just grind the toes, they don't elevate. So look at this other slow motion video focused on the hind feet, and you will see that there is a dragging of the toe because the horse is not elevating his toes, and they kind of come and kind of follow the surface of the ground. Okay, so that's quite interesting. The other thing is on horses who do have issues with the the trot on the lunge line, they will have a position with the lunge line which is interesting. Let's look at this horse right now, and you can look at this horse right there. So I make a break right there on this horse. Look at this position. It's completely oblique to the ground, a bit like a motorbike doing a turn to the right, compared to this horse over there that we will watch again. And if you look carefully, this horse will have a nice angulation with a lunge line, and it will be perpendicular to the ground. Okay, look at this. This is perpendicular to the ground. This is perpendicular to the lunge line. This horse is not perpendicular to the ground, is leaning inside. The lunge line is also shorter because this horse wants to go inside of the circle. This is the attitude on this chestnut horse of a typical low back, sacroiliac, lumbosacral pain, because the horse wants to do a smaller circle with the hind leg because he cannot extend his back and pelvis properly. This horse is sound for me. This horse is not sound and is unhappy with his hind part of his back. So when it comes to the bending of the horse, this is a summary of what I was telling you. A normal bending to the left, a horse with a dorsal pain which completely inverts like a banana shape. So the head is outside, the butt is outside, and he leans inside, but only with his thoracic area. The lumbar and sacroiliac, they look similar because the horse head will go outside of the circle to balance, but the hind part of his body, the hind quarter, will go completely inside. So that's the way the horse will behave and move inside of his body. So this lumbosacral and sacroiliac abnormality will show up on a circle with the head going inside with his butt. Sorry for the dogs, it's a lot of movement here. So when you have a horse moving on a circle to the left, for example here, this is a horse who has a hard time to collect his hind limb and flex his back, and this horse, you see, cannot go forward. So this horse has what we call a cold back. When he warms up, it's going to be a bit better. But if you look at this horse under tack and you don't ask the rider to trot right away, he will look almost normal. And this horse stayed at our clinic for 1 month. And I think it's very important for you to know that, again, if you look at the horse only cold, you cannot have the answer. If you look at the horse warmed up, then maybe you will find something wrong. This horse was suffering from strong arthrosis at the level of T18, L1, L2, and that's how he was moving when he was cold. But again, under tack, moving for 15 minutes at the walk and then picking up the trot would not be as bad as what you see on this video. So that's another test you can do, is using the surcingle or the saddle. This horse has actually looking quite normal, okay, with a good stride, not a great motion of his back, but quite normal. This is the same horse with the girth. Starts to be a little bit shorter with his front end, okay? And now again, the same horse, but with a saddle, and way, way shorter, okay? So these are horses which are showing different attitude because of how they look like with the surcingle or the saddle, because they don't squeeze and don't push at the same level of the back. So if I have to make a guess when I look at these 3 videos, this horse has more thoracolumbar issue than thoracic issue, because I think this horse is much worse with the saddle than he is with the surcingle. Okay, you're going to watch again. You have an idea of how this horse motion and movement is changing. He's actually lame with his left fore when you look at these videos far right, with the saddle on his back. Okay. So this is again test with the surcingle. This is a horse who has a normal surcingle test. He does not mind. Maybe he elevates his head a bit more. It's actually a horse from the Chilean team. So you see we have some South American horse on these videos. And this horse was just, trying to cope with the surcingle not too bad. I don't like so much the head position, but I would say it's within acceptance. This horse for sure does not like at all my test and is completely freaking out, as you see, moving forward, elevating his neck, changing his back motion, and is completely behind. This is a dressage horse that you see on a circle with a surcingle. So you always want to do this test on a soft surface if the horse really rears or fall down, because it will be safer for him. And then you watch the same horse with a block that I have done at the level of the withers. This horse had kissing spine, we have seen afterwards. And for sure, once the spines are blocked, with only 10 cc of lidocaine on both sides of the withers at the level where my palpation was the most evidently sore. So it was on this horse T14, T15. I injected with 10 ml of lidocaine, and he ended up to have a very normal canter on the lunge line. If you do the blocks to prove that the source of pain is in the same area, you want to make sure that you don't warm up the horse too long. You go back to your clinic or to your stable, you scrub right away, you block right away, and you go back on the lunge line right away. The reason why is because these blocks tend to be very diffuse very quick, and if you wait too long, it will diffuse on the whole back, and then you don't know which part has been really blocked. So between this video and this video, there is basically 10 minutes maximum, because the time I came back to scrub and to inject the back with lidocaine. When it comes to the horse in competition or in the undertake, you can also do a few tests. If you have some riders, they like to share their videos, they want to show you what is wrong on the horse, you can always look at different videos and see which part of the back motion is not as good as it should be. And so it's important for you veterinarians to have a good knowledge of the horse discipline or what your rider is asking. Some other things you can see for sure is a concomitant lameness with the back problem. If a horse is sore in his back, and here on a horse who has a chronic suspensory, you can see that the rider is sitting on the one diagonal, then change the diagonal, and you get the horse much lamer again. And the reason why is because this horse has a concomitance of a suspensory problem with a back problem. So sitting on the wrong diagonal at the trot for this particular pony made the lameness way more accurate. So the lameness is increased by the diagonal of the trot, and obviously because some back issues are also present on this particular case. Okay. So when it comes to the saddle, obviously you need to have some knowledge about the saddle fitness. This is a different, let's say, part of the exam. I could spend hours to talk about saddles, but I think it's we can wait for some questions. The main deal is to have a saddle which loads evenly on the back. Unfortunately, you can do all the best saddle fitness you want without the rider. Once the rider is on, as you see, you can completely change the position of the pressure on the back. So you look at the saddle, it's one thing. You want to look at the saddle with the rider to have an idea of exactly where the load is maximized, because unfortunately, this is something that might change depending on the level of the rider, the position of the rider, and if the rider has any problem himself, for sure it's going to change the pressure on the back of your horse. So what I also recommend, which is a very easy test for you and very cheap, I like a cheap test, so it's not expensive to do. You can take the saddle of the horse, you can wet the whole back with a sponge, you can put the saddle on the horse, the rider on the saddle, walk for 10 minutes, and then you take off the saddle and you see on the leather of the saddle what part has been more wet and what part is going to dry first. The reason why is because when it dries first, it means that there was maximum friction, maximum weight and load, because the water will evaporate quicker where the maximum pressure was. So it's a cheap thermography. This is expensive. You can do the same, as I told you, with just a sponge by wetting the back of your horse and put the saddle on. So now it comes to something which I really like to do, and people always make fun of me, because the rectal palpation is going to give you a good idea of one muscle that you can really not palpate otherwise, which are the psoas. And when I do this test, I'm going to check the psoas pressure, tension, and you can palpate the psoas all the way forward where they insert. They insert very far forward, so it's no chance for you to have your arm long enough to go to T14, T15. But at least you will palpate the part of the psoas which are inserting caudally on the femur and on the pelvis wing. So that's interesting because these psoas muscle, as you know, are part of the core muscle, and they are the main muscle to help the horse to flex his pelvis. So any work of collection, any work of movement to get the pelvis forward is only and mostly related to the iliopsoas muscle. At the same time, you can palpate the pelvis shape, you can palpate some of the nerve roots, sciatic femoral nerve roots, and if you have a mare, you can check the ovary glands and the uterus to make sure there's nothing wrong and painful, which could be interfering with any low back pain. I have always example of mares which are very sore in their low back, which sometimes have bad season and painful in their ovary glands, sometimes a problem with ovulation, or just chronic uterine infection. I had a very good mare, which was injected a couple of times in her back, never responded well on the long term. And this mare actually had a chronic uterus infection that we cured, and everything went back to normal. So don't ignore internal problems of your horse as well. When it comes to castration scar tissue, I know a lot of South American vets still do a castration standing or even lie down, but you may have sometimes some scar tissue or some adhesions between the inguinal ring and the cremaster muscle, and these are super painful for the horse, and they will mimic and they will look like horses who have some pelvis pain. So for me, there's always some place when you can look at the place where the horse can be sore. And if it's a lumbar axial skeleton problem, most of the time I made a list of things which are highly potentially the problem that you may face, which are epiaxial joint disease, so the little joints of the back. You can check the intertransverse joints and transverse processes of the back as well. And it could be only muscle soreness, like if you have a muscle tear or a muscle which is sore, like the gluteus, the multifidus, the psoas. These horses may behave with a mild or difficult movement of their low back. Most of the ligament injury I see, but which are underdiagnosed, are the lesion of the supraspinous ligament on the top line. And finally, you may have all kinds of neuropathy. As I said, if you have a joint disease and you have the nerve roots which are close to the joint space, you will have some potential atrophy of the muscle and dysfunction of that particular muscle, most of them being the multifidus and the gluteus muscle. So the clinical signs are always kind of the same. We spoke about it before. You have a defect of back extension on the jumps. You can have a frozen back. The horse may change lead in turns with difficulties. The defect of push for most of the rider is easy to feel and not always easy to catch for us veterinarians. So the defect of push is maybe the sign that most of the riders tell me is coming up. So when you look at the horse on the jump, it's also interesting to see that some of these horses don't want to extend very well the back. And that's a nice schema from Jean-Marie that shows that if you have a thoracolumbar space or a lumbosacral problem, these horses will continue to keep their pelvis in a forward position with a contraction of the iliopsoas. So if they contract the iliopsoas, they will not extend the hind end. Okay, so if I come back to this video that you saw before on the slow motion, look at this horse over the jump. You expect the horse, when it comes to be on the top of the fence, to extend his hind legs over there, but he's not extending so much. And then you get this feeling that these horses can have a forefoot. Look at the closeness between the hind feet and the pole. So these horses are good candidates to have a lack of extension and potentially less scope to cover the fence and to create a potential 4 points on this part of the fence. Okay, so when you look at this, you understand very easily that a horse who has a chronic thoracolumbar problem or pelvis issue will not have the full extension and therefore will protect himself by contracting his psoas and abdominal muscle. This is a kind of the same scenario on horses in Western performance, but I have the same on polo ponies. We underdiagnose this supraspinous ligament desmopathy. So these horses may have a thickening of the ligament that you see very well on the scan. They can have avulsion or chronic remodeling of the spinous process on the top. So that's easy to see either on X-ray or on ultrasound. On ultrasound, it's very easy to see because you will be seeing asymmetry and hypoechogenicity of the ligament within 2 spots or 3 spots between the spines. So don't look to always have a normal spinous process. Most of these ligaments here are in between the spinous process. This affects strongly the ligaments. So when it comes to the top line again here, you have small details of some hypoechogenic finding, but this image you can get even with a rectal probe. You just need a linear probe to do this image, and I promise you it's very shallow. You will be amazed by the number of findings that you may have on a horse who has a chronic back pain. Check always the supraspinous ligament. It's a very important ligament which connects, as you know, with the gluteus and hamstring muscles for the horse to collect and be able to flex his pelvis with a nice contraction of his psoas and rectus abdominis muscle. When I have lesions like this here, the treatment is kind of easy. To me, I like to do PRP injection and I like to do shockwave, and I follow these horses after 3 weeks, 6 weeks, and they do mostly lunge line during the rehabilitation. I for sure don't like to put a saddle and a rider on their back the time they are healing. So this is another disease that is pretty common, the epiaxial joint disease. The epiaxial joint disease, as you know, is a remodeling of the bone and the joints at the level of the facet. And we have tiny, tiny facets here on the top line. And most of them are painful or having lesions from T16 to L2, L3. But it depends on the discipline a lot. You can see more thoracic problems on some race horses. And I see personally more T16, 17, 18, L1 on show jumpers. So it could be discipline related because it depends also of how flexible the back is supposed to be and how much range of motion you can get. But if you see on this horse, on the left side, you have a nice remodeling and bone spur at the level of these joints at L1, L2. And here on the right side, this facet is almost normal. And this is the facet joint space here. If you have a big spur on the outside, this is not the joint. This is the mammillary process, and this is normal. The joint is a bit within this part here, more internal. Okay, so you have a big spur there. The multifidus is making like a triangle shape, and if it's well muscled, this multifidus can be almost like a sail of a boat. Look at the big yellow shape here. That's your multifidus shape. That's a nice multifidus, very well muscled, let's say. This is on the top your gluteus, and this is your longissimus muscle at the level of the lumbar facet. Okay, so this is easy to see. Like this horse here has a chronic facet disease. He will invert, he will try to elevate his neck. These are horses which don't want to elevate their mid-back. So when they canter, they look like a bathtub, they look like a rocking horse. They don't want to elevate the back, and they have a poor push of the hind end. When it comes to the facet, look at these joints here, which are very remodeled. So this is a specimen where you have a significant amount of facet remodeling. This is a normal facet. This is a very abnormal facet. This one has a lot of bone changes, bone formation around the joint. This is a normal joint. This is a mid-normal joint. This is a severe joint disease. So when you have a severe joint disease, like on this horse here, you have a huge amount of bone remodeling, which is seen very well on the scan. This is mild, but sometimes it's completely making a big shadow of bone, and you cannot even see the facet. On the bone scan, they will light up. This horse will light up here at the level of the apiaxial joint. This is more like a spinous process impingement. This is more like epiaxial joint disease, which creates uptake at the level of the facet line. So this is interesting because you see on this facet, when they are not even remodeled, you have the joint space, but just behind that joint space, you have a nerve. And this nerve is coming from the foramen at the level of the back and at the level of the vertebrae, sorry. And these two nerves, one is going to give innervation to the multifidus muscle, and one is coming very close to the facet joint. So these nerves are the ones that you could also block when you do this type of injections at the base of the facet. And so be careful, because when you inject this nerve, the horse can be much, much better. It might not last, but this is also significantly interesting for horses who have a lot of joint disease or foramen disease. So these nerve roots are very important and interesting to follow up sometimes with your clinical exam or by blocking locally. Okay, this is a good article that you can find from Jean-Michel van der Weerde from the University of Liège and Francis Desbrosses as well. So it's always interesting to see that these innervations are more important than we think. And I think on the back, we always think only about the muscle and the joint of the back, and there is a lot of neuropathy which are behind this type of pain. And finally, you have the multifidus muscle disease, and this muscle inserts on the spinous process, so you can see here, and it will insert on the transverse processes sideways on the left and the right, and it can insert from 1, 2, 3, 4 facet joints. So it's a very long muscle which attach very close to the spinous process. We call it a pennate muscle because it's full of a lot of white fibers, and it has a lot of proprioception fibers inside. And these proprioception fibers are responsible of the core and also the way the horse holds his back in space. So I think it's important to know for you that if you do have to work with these multifidus problems, you will see on the scan sometimes more echogenicity, more echogenic findings. And these echogenic findings are easy to catch again because they are very superficial. And this would be a normal muscle. This would be an abnormal one when you start to see some lines in between. I will show you more pictures right there. Sorry, I just missed this one. But you will have more remodeling within the muscle. So the muscle will be not as strong and bulky like we saw before. So you will start to see, instead of a convexity, you will see a concavity, because this muscle, by being affected, this muscle by being affected will show a different shape, and it will be more echogenic, and this function of core will be lost. So these are horses which are always painful in the back. You don't understand why, because they don't have a good core and a good, stabilization of the back and the vertebrae. So when it comes to treatment and management of these joints, for sure you can do some guided injection or mesotherapy. The mesotherapy has a goal to relax the muscle all around the lesions that you have, because if you have a chronic joint disease like this one, it's nearly impossible that you don't have at the same time a strong muscle spasm. So you want to work on the muscle spasm and make sure that your mesotherapy will also help softening the muscle, as you know. And therefore, you can start a follow-up and rehabilitation with control exercise, which I like to do on a lunge line. I don't want the horse to jump too early, maybe 10, 15 days. If it's a polo horse, I don't want him to have a game before 10, 15 days. If it's a dressage horse, I don't want him to be ridden and collected too quick within 10, 15 days. The other therapy you can use to relax this muscle tension would be alternative therapies, such as electrostimulation, shockwave, laser, but also you can have all kinds of manual therapy. So if you have a good physio person or veterinarian who does a lot of physiotherapy and is involved with this, I think it's always good to create a nice teamwork around the back rehabilitation. When it comes to guided injections, as you know, you can use your ultrasound and you can put the needle for this facet, for example, in between your probe and the midline, and therefore the needle will go down straight to get to the facet joint. And this area of injection is very interesting because you get very specific to put maybe some steroid or some IRAP or some PRP inside of the joint or close to the joint when it's very remodeled. You know, you have to understand that when you have a lot of bone formation around, there's no chance you're going to go in the joint. You're going to create a periarticular anti-inflammatory effect, but you will not go into the joint. When it comes to the pelvis itself, so the sacroiliac, lumbosacral area, you have a lot of things which could be painful. Unfortunately, it's very difficult to know which part is going to be the source of pain because all these structures, like on humans, are very close to each other. So on human beings, once you have a good questionnaire from your doctor, they will put you in an MRI, and after the MRI, they will say, oh, you know, it looks more like your disc, it looks more like your SI, it looks more like your foramen, and then they can decide what they inject. So for sure, on the horses, we don't have the chance of this imaging, but again, it's about your physical exam. If you have been looking at all the physical exam I have proposed you before, it's just some keys, some suspicion, but you can be more suspicious if you can look at these structures with your ultrasound or with a rectal ultrasound. As you know, it's a nice technique to evaluate the shape of the lumbosacral space, the shape of the foramen, the shape of the sacroiliac joints. And all these structures, most of the time, have abnormalities when they suffer. So I tend, once I have made my clinical exam, to trust what I see on my ultrasound. If I have a bit of everything, for sure, it's tough for me to make a decision. But if I have a very significant finding at the level of the sacroiliac or ilium wing or dorsal ligaments, then I make my choice for treatments and follow-up. So again, these horses, the clinical signs are the same. There's a stress on the pelvis. They will have a hard time to do a quick flexion and quick extension. So typically, these are the show jumpers which don't want to jump as high as before or don't push as good as before. It's typical of this dressage horse who have a hard time to do a pirouette. It's typically the case of polo horses for my Argentinian colleague who have a hard time to spin and go back on the other side. So they will take 1 or 2 more seconds to turn around and go back to change the field. So these are these clinical signs that you know could be in relation with chronic lumbosacral or pelvis pain. So I have a few examples of horses jumping. This one we have seen before. This is a horse, for example, who has a hard time to jump straight. So he jumps always to the right. Each time he jumps to the right, he has a hard time here on the slow motion to be going on the fence progressively. So you see that this horse is not doing the job properly. So what you see on this type of horses is that they will try to change the direction and they will always go to the side where they have pain. So if a horse like this one here on this video has a right SI pain, he will jump to the right because the push of the right lead will be worse and he will shift his whole body on the side of pain. So that's why I like to look at these videos and compare if the lead and the change of lead will be important for me to make my diagnostic. Okay, so when it comes to a horse who has a chronic SI, that's a case of a horse here which is doing good. This horse will jump straight and have a good connection in between the two fans, and he stays pretty alert. Look at the same combination the same day with another horse who has a flat jump, 4-fold, and again 4-fold on the second jump. And if you look carefully in between the two fans, this horse, when he starts to connect, is again having a hard time to come back. So his head is up, the rider tried to head stride, the hocks are behind, the pelvis is not flexed. This horse will have to change the number of strides in between the two fans and obviously does not take off from the right position. When it comes to dressage, when you look at the pirouette or when you look at the horse from the side, the dissociation, which means the space between the two hind limbs will not be the same. The horse will not have his two legs very well spaced, and they will sometimes be together, which means that when you look at the horse, it looks like a rabbit who takes off at the same time for both hind legs. So this is typical of horses who have pain in the rear, pain in the butt, pain in the pelvis, and they will not dissociate well the two hind legs. So the bone scan on this sacroiliac joint problem are quite helpful because they really show up hotspots, sometimes more diffuse around the outside of the pelvis wing, and more typically exactly in the axis of the SI, which is a little bit more outside. So that's why on these images, we like also to do oblique views with the gamma camera for those who have a bone scan or read bone scans to see if this uptake is more lateral or medial. But as I told you, I don't always need the bone scan. If I have a clinical exam which is super suspicious about SI problems, I also can use my scan. So the scan from the top line is only helpful for me to check the wing shape and obviously stress fracture or acute fractures and follow up this type of lesion. So this is very typical, but these horses, they are not just counter-performing, they are really lame, as you know. If it's a chronic fracture, they can be counter-performing, but first you will see these horses very lame, so you will not miss ilium wing fracture within bone scan if you have one, but also with the ultrasound system. It's very easy to find. But this is a case which is interesting. It's a horse which was seen for a pre-purchase exam. And believe it or not, he was, as you see, very short behind, almost lame. His lame right hind, as you see, with the rider on his back. It's not very convincing, but you know, you could test the hock and a couple of things. This horse had a bone scan and ended up to have a mild stress fracture on the right ilium. So it's interesting to see that some horses may have, as I said, a mild discomfort and still show some very odd findings. But this one, I would say that I would not be able myself to make a diagnostic without the bone scan. When it comes to the pelvis, the good news is we can have this transrectal exam. And the imaging, which is the most aimful, is this technique that Jean-Marie Denoit has been describing, where you can put your probe inside of the rectum, and instead of looking at the ovary glands from the side, you can look at the top line and look at the pelvis and disc and foramen of the main last 2 or 3 vertebrae. So here on this image, when I put my probe underneath, I can see the lumbosacral space and the disc. So this is S1 here, this is L6 over there, and in between, for sure, I have the small disc of L5. So small disc for L5, L6, big disc for L6, S1. So this is something you can do with your rectal probe very easily. So even if you do only reproduction work, with only a rectal probe, you can do this exam very well. And these are some findings. There's a bunch of examples, but this is a small disc between L5 and L6 within normal. And here it's a collapsus of L6S1. So you don't see the disc anymore. You have a black gap because the disc is actually completely collapsed between L6 and S1. And so L6 and S1 are, excuse me, fused. So this is now the projection of putting the probe on the foramen on the left and the right side. What you see on the image now is a small cup like this, and this cup is the foramen just there. This foramen gives you an idea of the shape of the nerve also which emerge from this foramen. And at the level of L6S1, this root is one of the 3 sciatic nerve roots. The sciatic nerve root emerged from L5, L6, L6S1, S1, S2, and you can have an idea of the shape of the nerve, and you can have an idea of the intertransverse joint. So this tiny joint, which is just in front here, and this joint is basically the limit between L6, transverse process, and S1, transverse process. So this is why we call it intertransverse joint, because we have 2 transverse process with a joint in between. And this joint can be pinched or can be fused as well, because then if you have less motion of this joint, you can imagine easily, if it's sometimes completely fused, that the L6S1 movement will be not able to be done. Therefore, the horse will be having a lack of flexion of his lower pelvis. This is a case where the foramen was showing a spur. So instead of having a big, nice foramen here, I have a piece of bone which is coming from the intertransverse joint and which obturate progressively the foramen size. So these horses, you can see sometimes these spurs, and I can see them on the scan, they will obturate and pinch the root of the sciatic nerve. So you can imagine that these horses could have the clinical signs of a sciatic pain like on human beings, and for them it's a very strong pain. They warm up from it like humans, but when they are cold and we are not pushing off the ground, this part of the sciatic nerve being pinched, it could be a very painful condition. And so we inject them from the top the level of the lumbosacral space. So it's a bit like a sacroiliac joint, I will show you, but you will inject a bit more close to the midline. So again, these sciatic nerve roots, this time I can see them from the side. It's a bit more technical this time, but these are a nice specimen to show you the share of the nerve roots. So this is your sciatic nerve, and it's coming from L5, L6, S1, S2. So these are the three emergence roots which converge to make the sciatic nerve root. It's a nice paper that we have done with one of my interns, Pablo Espinosa, and is from Spain. And we did this necropsy in France and in USA to get a full amount of horses, with total of 28, where we could see if there was some variation of the nerve root and the foramen size. So it's interesting because you can measure that with your ultrasound. You don't need to dissect the horse each time, which is good news for the horses. Anyway, coming to the next step is also some survey about equine practitioners. When I ask these practitioners what they think about a horse who drift on a jump, most of the time I get a front limb related pain on the same side. And the second most finding is the SI, so sacroiliac joint issues. And the main reason for them to have a defect of push is the SI joints again, but this time first place 50%, stifled 30%, and HOX 20%. So these are very raw numbers, but I wanted to share that with you because it means that if you have a horse with a defect of push and you continue to inject only the HOX or the stifle, you might make some of these horses not happy enough to jump the best again. So if you start to be good at finding this SI joint or lumbosacral joint disease and you can inject them properly, you will see a big change in the push, and obviously you will make your horse and client happier. So I can only emphasize that part. The other study that we did in our clinic a long time ago, it's almost 10 years now, it's actually 15 years now, it was interesting because I asked one of my residents to look at all the horses we injected and the one which were very well documented, because we did mostly 12,000 horses injection of SI in 2000 up to 2020. Sorry, at the time it was 2008. So in 8 years we did 12,000 horses, but we only had 135 cases where we had a full follow-up, including some bone scans and everything. So I wanted to keep only these 135 cases, and we find out that these horses' related pathologies were chronic hind suspensory problems and medial stifle compartment distension. So when you have a horse who has a chronic stifle distension, but is not so lame, but has a defect of push, look at the SI. If you have a horse who has a chronic suspensory behind, try to look at the sacroiliac joint or lumbosacral joint, because these horses will abnormally weight on their suspensories. And so it could be chicken or egg. You can have both problems at the same time. But I think if you treat only the suspensory or only the SI, you might not have the best result. You have to think about looking at the cause of a chronic suspensory or the cause of a chronic SI. So that's where I really like this study, because it opens our eyes a little bit about concomitant problems with the pelvis issues. So this would be some other example of how you look at the SI, but when your horse has a chronic SI, the other thing you can see is horses which are pacing inside. So they are coming with a hind limb really inside of the track, and these are the 5 or 6 findings which we find the most, which are tracking narrow behind. They do a lateral walk, so they go sideways. The haunches don't go in and out properly, but this is we discussed already on the circle. They can have an asymmetric tail position. When they canter, they can have this bunny hop, so the rabbit type of canter we spoke on the horse doing pirouettes. And obviously, they have a reduced flexibility of the lumbosacral space. So when I come back to the SI joints, here we can see some images of where I place the probe. So the probe will go outside of the midline, to the left to look at the left side, and to the right. And this is your sacroiliac joint here. So my rectal probe will be going sideways to evaluate this joint. And I don't say it's a very easy ultrasound to do, but if you train and you look at this image, this would be your ilium wing. This should be your sacrum. And so in between, you have the sacroiliac joint. So look at this small schema here, and you can understand a bit better what you see on the top of this image there. So this is not always easy to get, I agree, but you will look at these different findings. And when you have changes of the sacroiliac joint, you will have some spurs on the top, you will have some remodeling at the base. So this one, for example, is a nice joint. This one is very remodeled. You have spurs. I cannot see the joint space anymore. The helium wing disappears. It's very flaky at the base. This one is even worse. You see a lot of small line, like the tile of a roof. And all these small lines are small spurs, osteophytosis, coming from the sacrum towards the ilium. And these are findings of a chronic sacroiliac. Here is the same, a bit less easy to catch, but this one is very obvious, okay? So when it comes to injections, for those who have been injecting SI before, you just go oblique under the wing. This is what we call the classic blind sacroiliac injection. You go under the wing and you aim to go somewhere there, which is a sacroiliac. You can guide your needle under the wing with an ultrasound. And when you do lumbosacral injection, you can go parallel to the line here, parallel to the midline, approximately 4 or 5 centimeters away. And your needle will go again under the wing and aim for the lumbosacral space. So this is where your needle will be, next to the foramen, next to the intertransverse joints. And your product will fill the gap. When you inject, for example, 5 cc, this is what I do. I take a syringe with 10 cc of Predef, 10 cc of saline. I mix together, this makes 20 cc, and I inject 5 cc here, 5 cc on the right, and then I go caudally 5 and 5. So that's 20 cc altogether to inject the sacroiliac. And it's not a difficult injection to do if you know how to use your ultrasound, but the idea, as I said again, is to make your needle go under the wing and hit bone, find bone with your needle, the tip of your needle, to inject either the foramen here close to the lumbosacral space or the SI. When it comes to finding the caudal aspect of the SI joint, I give you a trick here. There's different methods. There's actually 2 methods. There's one that Jean-Marie Benoit described, which is a bit more anatomic, but I think more difficult to find. For me, I follow with my probe parallel to the midline. So I am 5 centimeters away from the midline with my probe. And I follow this line of the croup, and I slide my probe, I follow my probe progressively. So these are the spots that you see here. I will maybe send you a copy of this slide for you if you want to find the sacroiliac joint, but it's easy to see that you will follow the wing, follow the wing, follow the wing. And when the wing suddenly disappears, so you get at the caudal aspect of the wing, you're going to get a gap here. And this gap is giving you the caudal ilium part of the wing. And the base line here, this line that you see, is the sacrum. If you go too much away from the midline, the sacrum will move because it's not the sacrum anymore, it's the rectum. If it's not moving, if it's nice and flat, this is your sacrum. So this small spot here, this junction between the two, is the sacroiliac joint, the caudal sacroiliac joint. Okay, so this is where you will inject. You will have your cranial approach, your needle will go under the wing, and you will have your caudal approach, and your needle will be just behind the helium wing here. It will come all the way. And this technique is nice because you see your needle all the way within the sacroiliac joint. And a lot of studies have been made with latex or with methylene blue. And we have proven that this technique is nice because it really goes within the joint easily. We have a small video to show you that you can follow the needle, follow the wing first, sorry. This is your sacrum, this is your ilium, and the needle will come from behind, okay, because my probe is there. The needle comes from behind. We will adjust, this is your base of your sacrum over there, so we will adjust the image a little bit more. So I hope you see the video well. And this is your ilium wing, this is your sacrum. You see the movement underneath, this is your rectum, so you don't want to inject there. You want to inject just here at the base, okay? And your needle will come just at the level of the sacroiliac joint, caudally. I'm sorry it takes some time, but you'll see the needle arrive here. Here we go. The needle just will aim to the edge, caudal edge of the SI here. Okay. I don't go here. This is a rectum. You don't want to go there. Okay. Anyway, one other pathology we can talk about are the psoas problems. The psoas inserts, as I said, on the femur and the pelvis wing. So you may have tendon issue of the psoas, like on human beings. The psoas pain is huge when you have a tendinopathy. And if you have a disruption or a chronic tendinopathy, these horses will not be happy to collect and flex for the same reason as I said before. So we don't want to have that. So unfortunately, it's only a diagnostic you can make by palpation and ultrasound rectally. When it comes to the last type of injection I wanted to show you are the psoas injection. These injections are interesting because you are not obliged to go in the psoas themselves. You can stay on the top of the psoas, or you can be in between two transverse spines. The needle will go straight down, vertical down, and to tip and feel the bone on the transverse process. So your needle does not go all the way into the psoas, all right? And you just see my point here. I can put the video again. This is the midline on my finger. This is 4 or 5 centimeters away from the midline. My needle goes all the way, and I feel bone. I am feeling bone here, and I inject the psoas from the spout. It's important to inject the psoas when the horse has a chronic pain of the pelvis, or even if it does not have any, because the psoas need to be released for the horse to extend and collect better again. Okay. Finally, two type of problems that you can get which involve the pelvis, which is the coxofemoral joint. The horse coxofemoral joint, as you know, is a very deep joint. This is the videos that I have taken with my wife, where you see that the horse has a problem to do a nice round shape with his right hind compared to the left hind. So this horse had on his right hind a severe capsulitis and inflammation of the coxofemoral joint compared to the left, which was very smooth and have a nice shape. So when you have the chance to see these horses who have a hard time to describe a circle with the hind leg properly, you can suspect that they can have some coxofemoral pain. So this horse obviously was examined cold. Then I scanned it, I compared left and right, and this is what he was showing. On this video, if you see the video well, I hope, this is a horse who had a chronic sacroiliac and coxofemoral, but he was lame. And when a horse is lame, I don't think immediately about sacroiliac. I think about the joint problem. And when I blocked him, he was much better on his right hind. So hopefully you can see the videos, but these horses respond very well to the block. And I block ultrasound guided, my needle all the way to the coxofemoral joint, and I inject 10 cc of carbocaine or lidocaine. So when it comes to the coxofemoral joint, I can show you the technique very quick. I put my probe from behind. So this is the image you get. This is the head of the femur. This is the neck of the femur. And this is your coxofemoral joint just there. So it's a bit more here this way. And then I will put, I will put my needle under the probe and guide the needle all the way. So the needle, the needle will slide under the probe and go directly into the coxofemoral joint. Okay, so if you want to look more carefully, again, coxofemoral joint, the neck of the femur, the head of the trochanter, it will go directly there. Okay, that's your edge of the pelvis. So this is the pelvis, head of the femur, obviously femoral coxal joint just there. Okay, so not so difficult to do if you take the time to place your probe. And if you have a horse that you have a strong suspicion, maybe you don't block, you just inject right away. I know some people cannot block and come back because you have a lot of road to do. Ideally, I'd like to do both at a time, but you can block and inject the same day otherwise, and so you don't have to come back to check this horse again. So the follow-up treatment, as you know, is using different drugs. I am not a fan of using always steroids on all these horses. So normally I treat them with some anti-inflammatory drugs, which could be non-steroidal, but for the psoas and for the muscle pain, it's always better to use mostly Dex or flumethasone I don't know if in South America you can find flumethasone anymore, but in USA and in Europe, it's tough to find now. And more and more, I use PRP, I use PPP, and we can discuss this a bit later when you have questions, because I have really good results. For sure, all the rehabilitation that you may use with control exercise, laser, shockwave, functional electrostimulation are very good product to use. And again, I can keep this for the discussion after this lecture. Okay, so just to show you the last slides of what we can do now in the future, this is videos that we have done at home. I'm sorry, I just want to check that again. We are using motion capture video nowadays, and we use a bunch of cameras to check the motion of the back, the motion of the hind legs, and for sure this might be the future. I am happy that we have this system now to use at home, but it's a bit too much of a high end. But when it comes to counter performance, this is really the way to be objective with the findings, because otherwise the riders, they can push you to do some things that you don't see, and you end up to inject very, random stuff on a horse, and I don't think it's the way to go. I like to get a bit more science credit, but you are still there to please your horses, please your clients, so we end up to do sometimes strange type of injections. Sometimes it works, sometimes not, and that's why I want to be, as always, a bit more specific and accurate with what we do. So the conclusion is, again, the clinical exam is amazingly paramount. If you don't do a good clinical exam, if you don't have the technology, you will not go any far. And that's why I think the back and the pelvis is super interesting for us, and especially for you who are clinicians before doing too much imaging. And that's why I tell you there's a big difference in what I see in North America and what I can see in South America, where people are trusting their hands more than the imaging and the technology. So I just can emphasize one more time that it's important for you to develop your anatomy skills, develop your biomechanic findings, try to understand the type of segmental pain. You have to be good in neurology. You have to be good at knowing the discipline of your rider, so you can understand these counter-performance issues. Okay, so I am done for today, or at least for the... Now we can go to questions. So I will open my camera again. I hope you can see me maybe again. I don't know.
Yeah, we are seeing you again.
Okay.
Doctor, I'm good with questions. One of the question is, which products do you use for mesotherapy?
Okay, so for mesotherapy, it's very important to use only lidocaine and or flumethasone. You don't want to use DEX, especially in South America. You have a lot of sun. It's the same here in California. So what I want is to make sure that when you use lidocaine, you can actually use only lidocaine with saline. This works really well because you are doing a gait pain control technique. So when you do your meso lines on the horse, I like to do 5 lines on both sides. And so the 5 lines, normally I need 40 cc of liquid, and I use 2 syringes of 20 with 10 saline, 10 lidocaine. The lidocaine is the best because it has also a vasodilatator effect, and this effect will activate the tiny glomerulus reaction of the nerve that you have on the pathways lateral to the back. And some people who like acupuncture have the feeling also that you can work on the bladder meridians, which I think is a good thing for relaxing the top line. So don't use DEX, don't use steroids, otherwise you're going to have these white bleaches on the top line of the back. It's going to be a mess.
Okay, another question is about what drugs do you prefer inject in the sacroiliac joint, and what amount of that drugs do you use?
Okay, so well, as I said, if you have Predef in South America, which is isoflupredon, you can use Predef 10 cc and 10 cc of saline or Sarapin or something to dilute. Normally, I think Sarapin is very expensive for what it is. So I use saline with 10 ml of Predef, and this makes 20 cc together. And then I will inject 5 and 5 left and right cranially, 5 and 5 caudally. So 10 of Predef, 10 of saline. If you want to use other steroids because you don't have Predef, you can use triamcinolone. In this case, you can use 40 milligrams maximum of triamcinolone. that you will dilute to get 20 cc volume. It's important to have 5 cc because the 5 ml is enough to kind of diffuse around the joint cranially or caudally or both.
Okay, anybody else has a question or a comment?
I saw a question about DEX. For the DEX, for the meso, you have to be careful because the DEX, even the sodic dexamethasone, can kill the follicle of the hair. So if you do a good meso, which means a deep meso, some horses which are chestnut or bay can end up to have a local bleaching as well. So especially, you know, in South America, you have a lot of sun and the UV interact with the DEX to create this follicle death. So you will have bleaches in most of the time.
Okay, anybody else wants to ask something about it? Okay, in one slide, I saw a treatment with Traumel. I wanted to know your own opinion about the product and if you use frequently.
Yes, okay, so I like Traumel a lot because it's, okay, for sure it's a bit like water for people, but I do have the feeling that using this arnica liquid, when you do a mesotherapy with it, you have a longer mesotherapy. I have done, I don't know, maybe 20,000 in my life. So I have had time to test on the same horse to do only water, only saline, only Traumel, only Dex, only whatever. And the Traumel has been always pretty good to me because I still have a good result, which lasts at least 6-8 weeks sometimes. Because you remember that when you do these tiny injections with the meso, you really have a huge gait pain control. So it's very common to have a result of muscle relaxation.
Okay, doctor. Anybody else wants to ask something? Or comment something? I think no. Dr. Benoit.
I saw a question about complication, no? ¿Puedes preguntar qué complicaciones ha visto en disecciones?
Okay, yeah.
Okay.
Yeah, complication. Sorry. In case of compromise of the sciatic nerve, do you observe any lameness in that horses?
Yes. So they are not lame. So that's for Luis. It's a good question. These horses with sciatic pain, when they are cold, you pick up the leg and they react. They don't want to flex all the way or they don't want to extend all the way. When they are super cold and you walk them right away, they have a defect of caudal face and cranial face. And as soon as they warm up, most of the time, they look good to watch, but they can drag the toe on the ground, okay, like a horse with a lumbar pain. And when they are ridden and cold again, the rider always feels the horse not pushing off the ground as well on that limb, if it's an asymmetric sciatic. Once they warm up, they look almost normal. And once they jump or they have to push off the ground strongly for dressage or pirouette or spin for Western performance horses, they are very weak on that side. So you don't see a very significant lameness. It's not always easy to catch. And that's why it's super good question because I think these horses, we miss a lot of them.
Okay, another question is that if you have seen complications in injections of the hip joint and if you have experience in radiographs of the hip with portal X-ray machines. Okay,
so that's another good question. On an adult horse, to look at the hip, it's not very easy with the X-ray. So if you have polo ponies, small horses, you can still do X-rays. Not always easy to do as well. But anyway, I think the ultrasound is interesting. First, because you can have a good idea of the distension of the joint. And when they suffer this joint, they always get distended and you always have the margin of the joint which are not looking so good. There's many ways to look at the joint. You can go all around the joint with a method with ultrasound, like almost like around the clock. I like the one from the caudal aspect because this is the one I do the most. But you have a very good paper of Maribeth Whitcomb, W-I-T-H-C-O-M-B, Maribeth Whitcomb from Davis, which is going around the clock. So that's for the ultrasound. Now, the complication is when you miss, when you see a joint which is really distended and a lot of fluid and a lot of complication around, and especially if it's very asymmetric. First, these horses are lame, they are painful. And two, if you inject them with steroids and they have not too much time off, they can be much, much better and then much worse. Because I think this joint, we cannot evaluate the round ligament position. And sometimes the head of the femur is a little bit outside. And these are the ones that I am feeling that we have a distension of the round ligament, which means a joint instability, and the capsule gets more distended. So these horses, you inject steroid in them, they will get worse. So if I have this suspicion on these horses, to avoid complication, I inject them right away with PRP, and I give them more time off than a normal injection.
Okay. Do you use depot for SI injections?
Not a lot. No, the reason I don't use depot is a lot of horses do FEI shows, and the depot medrol is at least 30, 35 days withdrawal time. The second reason is when you inject depot, sometimes you use the depot and sometimes you don't, because you don't shake the very evenly. And so I never know how much dose of salt I have. And third, I think I have a very good result without using depot with other drugs which are not as aggressive and as long lasting. So I prefer to use Predef or Dex. And I can use Dex in a SI. Like if a horse has a show in 10 days, he's very sore in his SI, the clients wants me to try to help the horse a little bit, and it also helps for diagnostic. You don't have to block and you get the horse into the joint to see what's going on. You inject with Dex, the horse will respond well. And then if the horse has more time off after the show or 2 weeks later, you can re-inject the horse with something else which is more long-lasting, like Predef or triamcinolone, or you can use orthobiologic. So you can use PRP or IRAP or a combination of something that you like.
Okay. Another question is, can you tell us, please, about the therapeutic action of shockwave? Is enough for coxofemoral joint?
So for coxofemoral joints, I have seen horses with shockwave only when they have just a capsulitis or pain around the capsule. And I think this is well described in the same for fetlock or stifles, which respond very well. If you have bone formation around the capsule, if you have any organization of bone and fibrous tissue, the shockwave can make the horse more painful for a couple of days. So unfortunately, it's tough to make the diagnostic to say, yes, it's a shockwave case. No, it's not a shockwave case. So what I used to do at the beginning is I just shockwave, give 1 day off, and look at the horse. And then for every horse, I have seen results which are inconsistent. So I cannot say it's a good or bad thing. I think you just have to try depending on the case. But what I can tell you for sure is that horses who have significant amount of bone formation, fibrous tissue around the joint, and you cannot see very well the limit of the capsule and the joint space, don't use the shockwave. These horses for sure will be sore with it. Most of the time they will be sore with it, let's say. There's no one left. Hello?
Yeah, I'm here.
Sorry.
Another question is about this. If you only find alone the sciatic nerve neuritis, or always combined with any pathology of the lumbosacral or sacroiliac joint?
Yeah, again, a good question. When you inject the sacroiliac joint caudally, you have the dorsal ramus of the sciatic nerve. So, you know, it's tough to say, but when you will inject this sacroiliac joint, you will have some product diffusing around. So a horse who has a chronic sciatic nerve root issue caudally will respond as well. So it's interesting that you cannot say that when you inject sacroiliac, you are only specific to the sacroiliac. So for sure, the sciatic nerve will be responding. Now, if I want to make sure the sciatic nerve is injected the best I can, the only technique we have for the moment is this lumbosacral technique. So I go under the wing, my needle goes inside, and it's going to hit the lumbosacral space, and then I am close to the lumbosacral joint and the sciatic nerve foramen. So this will help, I guess, the most. But it's a bit like on human beings. When you are sure that you have this type of problem, you want to inject sometime twice at 2 or 3 weeks interval, because the sciatic nerve, when it's really pinched and inflamed, it's not only one injection that will make the difference. So you are in a position to inject once or twice at 2, 3, 4 weeks interval for sure.
Okay, another question is, what is your opinion about muscles relaxing drugs like metocarpamol or dantrolone, and if you use it?
So I use metacarbamol a little bit. Sorry for the screen. I use metacarbamol a little bit, not so much dandrolene. Dandrolene is more for surgical outcome because, you know, it has a different type of mode of action. The metocarbamol, the funny thing is you need to have a good dose to make it work. When you lose this amount of dose in the bloodstream and you lower the dose, most of the time it does not function anymore. And the other thing I really don't always like with metocarbamol is when you stop, the ROS can be exactly back to where he was before. So if it's a muscle contraction like diffuse, and I use metocarbamol and this ROS have lunge line work, they use a pessoa rig or they use some equipment not to be under attack, and I give a chance for the muscle spasm to release completely, and I stop metocarbamol and they stay good, I am fine with it. So I use it as a tool to go to somewhere. But using the metocarbamol on a regular basis to keep the ROS in work when the ROS is tight and does not really untight when I stop the drug, I am not as convinced as using, for example, just a mesotherapy and get the pain away for sure and the spasm away for sure.
Okay, another question is, which biomechanics alterations in the jump maybe you can suspect about problems or lesions in the iliopsoas muscle?
Okay, so I showed you a video of a horse who goes with a hard time with his hind limbs. So I can come back to the video quick if you want, so you can see what I showed you. It's this video that we saw. Maybe sorry, Chuck, I have to go back to the main thing. It's going to be quick. Okay. It's when the horse has a hard time to extend the hind limbs. So if you can see this video quick again here, it's this one. So these are the iliopsoas, if you remember. Can everyone see my screen now?
Yeah, doctor.
Okay, so the iliopsoas, as you see, they insert on the femur and ilium. So anything which shows a defect of flexion extension will be like on this video. So look at this video now carefully and look at this horse on the jump. And you will see that he has a hard time to extend completely his hind end. You see, he gets frozen here. That's the maximum of extension of the hind end. Okay, and when he finished the jump, he's still not extending completely the hind end because the iliopsoas insert between the base of the lumbar spine and the femur and the base of the ilium wing, so the cranial aspect of the pelvis. So this horse cannot extend his legs properly. So this is typical of iliopsoas pain. If you look at a lot of horses who have this iliopsoas pain, also when you pick up the hind legs, they don't want to give the hind leg too much backwards. So sometimes it's the farrier who tells you, oh my God, this horse, I cannot pick up the leg and go to do my work normally. And in different disciplines, you have a different way of looking at it. If it's a Western horse, when they have to slide, they don't come progressively too much under and they don't extend well. If it's a dressage horse, it does not want to do nice transition at the canter. When it's a polo pony, when you spin, they don't like to spin so well. So everyone has his way to show how much the psoas could be painful. But again, it's not very easy to diagnose unless you put your arm inside and touch the psoas to see if they are tender or not. But it's a quick exam to do. You know, sometimes I just give the horse a bit of sedation, like 0.2 of detomidine. I put my arm inside, I squeeze the psoas, and I see if they are tender or not before I make a decision to inject them.
Okay. Doctor, can you share, please, your shockwave protocol to control back and lumbar pain?
So, which one, sorry?
Excuse me?
Share what, you said?
Your shockwave protocol to control
shockwave
back
protocol.
and lumbar pain, yeah.
Okay, so for shockwave, Okay, I use a radial shockwave, so sorry, a focal shockwave. So the focal shockwave I use per side of the back. I go on a meridian bladder meridians on both sides. I start at the base of the withers and I go all the way down, like if I do a mesotherapy, and I do 2,000 shocks per side. So it's 4,000 shocks altogether. If you have a segment of back which is very painful and not the rest, I can do shockwave only on this segment. And if this segment is less than 50 centimeters, I do only 1,000 shocks per side. And if I have a supraspinous ligament problem, I stay on the top and I do 1,000 shocks only on the supraspinous ligament.
Okay. Do you hear me?
Yes.
Okay. Have you heard something about mixed adrenaline and a local anesthetic solution for mesotherapy? Apparently reduce the absorption of the local anesthetic solutions and making better the effect. What's your opinion about this?
It's not a good idea because with the mesotherapy, what you want is a vasodilatation to activate the small ganglions that you have on the side. And these ganglions are very responsive to lidocaine more than carbocaine because you have this vasodilatation effect because they work with the vessel and they work with the nerve numbing. So adrenaline is not a good idea for this type of treatment. It's better to use adrenaline when you do a local block. When you do a local block, for example, of the withers or of the, for sure, like a local block of the fetlock, I'm okay to put adrenaline. But I don't want to put adrenaline in mesotherapy because it's exactly the opposite effect I want.
Okay. About therapies with ozono. What do you think about it? Yeah.
So I am not an expert, but I have met in Brazil a few colleagues who do a lot of ozone therapy, in Italy also, and they claim that they can have the same result as they have with mesotherapy because they do the local treatment of ozone on the whole longissimus muscle with a good relaxation. The main reason ozone was very popular in Europe maybe 10 years ago, it's because it was negative for FEI. So people would inject their horse with ozone 2, 3, 4 days before the shows without any problem, even the joints with ozone. So I am not a good expert about it because I have not used it myself as much, but the people I have seen using it have been pretty happy with it. Again, the main reason was about the delay for shows, for the racetrack or for the shows.
Okay. How do you treat an iliopsoas tendinitis?
So, yeah, I saw the question from, I guess, Luis again. Yes, for the tendinitis of the psoas, tendinopathy or psoas strain, unfortunately, you have to go through a period of rest. So you cannot inject, you cannot do anything, you cannot do shockwave. It's only about the rest. So it's a bit like on humans. On human, when you have a psoas tendinitis or adductor tendinitis, it's only rest. Some people can recommend to do some ultrasound, but the problem is how do you access to it? It's so deep. You can do maybe transrectal ultrasound therapy. No, there is no way you can treat beside giving some time off.
Okay. About the block of the intervertebral nerve, what do you use for it?
So for this one, because it's very local, I prefer carbocaine because it's more precise and I use a small volume, so it's very targeted. With lidocaine, you have this time, it's good to put adrenaline if you have lidocaine, otherwise just carbocaine, and you go inside of the, next to the foramen or next to the nerve, and you inject 3 or 4 cc of carbocaine per side. And it's enough to block a segment or a facet of the same area.
Okay. Another question is about if you use any anesthetic block for diagnosis of sacroiliac joint lesions, and if yes, in what, which volume do you use for the block?
So Sue Dyson was the first one to block sacroiliac, but she was not going deep like we do with ultrasound guided nowadays. So if you do a deep ultrasound guided injection, unfortunately with block, you are going to make the horse sitting right away. The reason why is because this poor guy will have a block proportionally of his femoral and sciatic nerve. So the horse will have no more push and he's going to sit like a dog, and you cannot do any more anything with this horse for at least 2 hours. So I don't block SI anymore. I tried and I got this result each time. So if you don't want to have a horse sitting in your room or sitting in a stable, don't block SI anymore. Unless you are very superficial, but then you don't really block the SI.
Okay. Which is your opinion about lameness locators for evaluating problems in the hip?
So for the hip, I think it's not a specific type of lameness. So the lameness locator will give you an idea of the leg, which is limb, of the limb, sorry, which is lame. But the lameness locator today, at least, does not give you an exact type of a diagram or graph, which is typical of the hip. But if some people in the audience or participants have tried the hip lameness with the lameness locator, I'm very happy to hear their opinion. But so far, I have not seen a specific diagram typical of a lameness due to the hip. Okay.
About laser, what laser do you use for the hip? Class 4 or class 5?
5. I never heard of class 5. I think the maximum is class 4. But okay, I use a class 4. But the class 4, even if you think it's good, it's going to help the muscle around the hip, but not the hip itself, because the class 4 has a limitation of 5-6 centimeters depth, which is already a lot. And the hip joint is at 10 to 14 centimeters depth. So I don't think you can treat the hip joint with a laser. You can only use the shock wave, or you can use the laser, but only for the surrounding muscle of the hip. So it's not as accurate.
Okay, and I think finally, what's your experience with radiofrequency therapy?
I don't have enough experience to talk about it, to be honest.
And the last one is, in Argentina, it's very common to see work the horses, right? With just, Diana, ¿cómo puedo decir eso? Un tapete. Una... Wait a minute, please, doctor. Diana, ¿estás ahí?
Like without a saddle.
Okay.
Oh, with a saddle. So, if I understand well, it's common to see the horse under tack with a saddle to see the movement and to see the examination, or not common?
It's common.
It's common, yes. Yeah, I think, as I said, when I went to South America a couple of times, I was very impressed by my colleagues' clinical evaluation. I think you observe a lot. You look at the horse in the stall, under tack, without the tack, and I think we can see much more. So personally, I do this all the time now. I look at the horse under tack, under the saddle, and if I go to a barn and I have, because everyone has, we never have enough time. So what I do is I like to do my physical exam in the stall. I put my notes down. I look at the horse jogging, do flexions, put my notes down. And if I start a second horse, then this first horse gets under tack, and I will ask specific movement to be done. So what I like the most is the figure 8 at the trot, under tack, changing the diagonal. I like to ask the horse to do a spiral at the canter. So they do small circle, big circles at the canter to see how they change the bending. And this gives me a lot of information. And second, if you can trust the rider, if it's a good rider, and in South America, I guess you have a lot of horse people which are very trustful, at least for the riding. You can ask them, what they feel, what you can do. And I always ask the rider, what is the difficult movement you have a problem with your horse? And if I can block that thing that I see, if it's a thoracic pain or a thoracolumbar pain, and the horse can do the movement that the rider wants to do afterwards, for sure it gives me a good idea of what's wrong. But I was hoping, in France, it's not so common to look at horses under tack. And I saw this mostly in North America and South America. And for me, it's the way to go. It's the way to get more information. Yes, that's a good point.
Okay. Dr. Benoit, I want to say thank you for your time, for your
You're welcome.
outstanding conference. It was awesome, really awesome. Thank you. Thank you very much.
Welcome.
And we hope to have you as soon as possible for us and for you. Thank you for your kindness and for your awesome knowledge and tips and everything you gave to us today. Thank you very much.
Well, you're very welcome. I hope everything goes fine for all my colleagues in South America. It's really a part of the world that my wife and I, we love a lot. Thank you.
Thank you, doctor.
Bye-bye.
We send a hug and a kiss. Thank
Okay.
you.
Bye-bye. Thank you.
Bye-bye. Thank you.
Bye-bye.